It's important that when you talk about cardiovascular disease, we need to look at the spectrum.
Yes.
Because we have what is called congenital, which people are born with, and those ones have always been there. And then we have what is acquired. Yes. And even what is acquired, we need to know that it depends on the age, because we have the younger children, probably between 5 and 15 years.
Yes.
And there's something that's very common called rheumatic heart disease, which is infective in nature, but then it develops into a heart problem and causes these complications. With time, perhaps the ability to diagnose has improved, and so we are seeing more cases being picked up. But then if you go to the older people, then now we start looking at what we call the lifestyle diseases, so that we get obesity coming in, we get the issues of use of alcohol, the issues of use of cigarettes, the sedentary lifestyle, lack of exercise. All those will contribute to possibilities of getting cardiac disease. So the two spectrums, perhaps the lifestyle has contributed to an increase for the older people. But for the younger people, we probably still have what we used to have previously. But the figures seem to be higher because we have improved in terms of trained personnel and in terms of ability to pick it up.
So the figures have improved, but also they're stating that Kenya lacks accurate statistics as far as figures are concerned. Why is there a lack of proper data when it comes to management of the data system to know accurately what are the exact figures?
Well, I probably wouldn't completely agree with them that we lack proper data, because we have an entire ministry that's been there for many years, and they've got a dedicated unit that actually works with statistics and data gathering.
Yes.
And of late now, we have these professional associations where there's Kenya Cardiac Society, there's the Kenya Medical Association, and people of interest in that. So they're all interested in gathering this data. So the only thing that's happening is that we are improving in terms of getting this information of ours. So it will not be accurate to condemn us completely and say we lack accurate statistics. There might be some gaps, but yes, we have the statistics. Yes.
All right.
Yeah.
Maybe you can weigh in also, Geoffrey Mwangi, because I think the National Health Insurance Fund also, you rely heavily on data for you also to make informed decision on where actually to invest what, right? Have you seen this disparity that is being alluded to by some of the pundits as well?
Yeah, well, as Dr. Elly has said, what we are having now is more cases coming up.
Yes. More
cases coming up because of the increased awareness. And as actually has said, the cases we have so far handled, we've seen the 5 to 20 years and the 20 to 40 years. They form the bulk of the conditions. And as he said, those are the conditions, either congenital or rheumatic. I'm sure they talk about that more. So one, yes, we need to progressively keep managing our data.
Yes.
Because that is indeed the right path to go. But we are getting there.
We're getting there.
All
right, Stephen?
What I would say is the most important thing that this country has done is to have equipment, diagnostic equipment across Kenya, and that has allowed many patients to access diagnosis at the early stages. In the previous years, you find that very few centers had capacity to diagnose heart disease, and the equipments were very expensive. Now we are seeing many centers well equipped, most hospitals are well equipped, more technicians trained to do diagnosis. That has helped us to have these numbers, despite having the shift in our lifestyle diseases, but I would say also our diagnosis has really improved.
All right.
Yeah. That's the way to go when we talk of non-communicable diseases, because the right path is early diagnosis.
Early diagnosis.
Early diagnosis means everything.
All right. But early diagnosis, I think also the challenge that really comes to the fore is, and you find most of the patients, maybe they have insurance cover, and part of insurance cover, they don't want you to also go and do a medical test, just get a thorough medical checkup, because I think of the cost implications as well. How can we also tackle this moving forward, Dr. Loice?
Well,
early diagnosis is very key.
Let me also comment a little bit on data.
Yes, data.
Before I answer
Thank you.
that.
Thank you.
Well, previously, we've actually not had a lot of data because of the things that we grapple with, the things that we have to tackle.
Yes.
But since some years back, not very many though, especially in data for cardiovascular disease. The Pan-Africa Cardiac Society actually set up a database and distributed to various countries. And we have one such a database in Kenya, which we are now filling since about 5-6 years back, so that as far as especially rheumatic heart disease is concerned, we are now beginning to get data, but it's an ongoing process. So we are not as ignorant as regards our figures as we used to be, but it's something which is evolving. And we are happy that we are doing that. Pan-Africa Cardiac Society is working with Kenya Cardiac Society locally to actually put in place one such a system so that we will be able to know how many patients are being diagnosed with rheumatic heart disease every year and what is our burden generally. But as I said, it's an ongoing process. Yes.
All right.
Yes.
An ongoing process.
Yes.
All right. I think even I've lost my track of thought on where I was asking you before you answered the data. I'll remember. I'll come back to you.
Yeah.
But
I want to take you back to the track because you mentioned something that has to do with preventive and promotive kind of health
early
services.
diagnosis. Yes,
that comes with early diagnosis. Yes. And we must then, from the outset, be very clear that we put a lot of focus on curative. So essentially, as a health sector in this country, we have put a lot of focus on waiting for people to be sick to come to hospital to be treated. Maybe it's about time that we found a way of going into public education and doing what we call preventive and promotive healthcare. Because, like, for example, what you talked about, lifestyle that will predispose you to get heart disease. Some of those things are very preventable if you know what to do. Yeah, if you know what to eat, if you know what exercise to do, and so on. If you know that you should not overindulge on certain things. So it's clear that it's about time that we actually started opening a focus on preventive and promotive healthcare.
Yes, which is very key, and I think also that alludes to the question I was asking you before in terms of insurance. I don't know if NHIF also is making sure that, yes, that we have maybe preventative measures coming to bear when it comes to having this early diagnosis as well, where we can go and be tested. I don't know if that is something that you're considering, because I think other insurances policies, they don't really advocate for this. So you go, you have, you discover that maybe it's cancer, and it's at a very late stage, maybe this is the fourth stage of cancer, which could have actually been prevented were it no earlier diagnosed.
What we've done, we've laid out an outpatient program. And the way we are operating it, it's meant over time to take care of early diagnosis.
Yes.
Because we are telling people you need to choose your preferred facility, you need to be seeing a doctor in this case, so that you are progressively managed in case of any condition coming up. The kind of situation we see here is when you run to the doctor when you're already critically ill, or when the condition has really gone beyond. But that is a cultural way we need to develop, that progressively we need to be managing our conditions early enough. National Health Insurance Fund has set up an outpatient program. The other inpatient programs you're coming up with are basically curative in nature.
But, and you'll elaborate for us also to understand what are the curative in nature and the measures that you're taking also at NHIF. Dr. Stephen, maybe you want to also contribute, especially with the private sector coming on board as well, working in concert with government. How has this harmony been, knowing that also right now there's a lot of donor fatigue, so to speak, and also we know, the donor money is contracting.
Yeah, no country in this world has ever gotten healthcare financing correct.
Yes.
Most countries they have strategies in place to provide proper healthcare to their people. Kenya specifically, I would say that the government has spent a lot of time to create awareness for people to understand the need of having an insurance. Most people did not have insurance. They did not have maybe confidence in insurance, and that contributed to the low percentage of people getting insured against healthcare, and that contributed to low uptake of people accessing healthcare delivery in this country.
Yes.
So with the information now going out there, and information is power, most people now have known that once they have the card, you have already prepared your healthcare, and should something happen anytime of the day or the night, you're able to reach the hospital and get treated. And with this universal healthcare coming on board, especially NHIF now rolling out many products on healthcare, and private sector insurance also working closely to provide holistic care, you find that we have moved a milestone. When the healthcare insurance came on board, there were several exclusions. But at the moment, you find that most insurance companies are covering non-communicable diseases, chronic diseases, which is a step forward. Because, and that's so, as I'm saying, information sharing. Most people are now going for health checkups. It's very common to women. You find that a high percentage of women go for healthcare checkup. It's also picking up in men. And we encourage every Kenyan to go for health checkups, and that will help arrest of the disease. At early stages, intervention is sought and solution is found, and usually the outcome is very good. Thank you.
Right, and I think there's a sort of people are very sanguine and happy down on the ground with what NHIF is doing currently, especially with this particular cover that can actually cover the non-communicable diseases that we're discussing here, cancer being one of them, and we know how also the rigors of finances that really can be sometimes destabilizing to a family when it comes to ailments such as cancer. We shall discuss this also much later. But let's move on and we talk about even now the shift that we are seeing, right, from the West to Africa. You alluded to the fact that obesity and lifestyle changes is contributing to this. But why is it that we have especially 85% facilities having vaccine for the children? Because I know you're a pediatric cardiologist. And only 25% of the country's health facilities stock essential medicines for heart diseases, stroke, cancer, diabetes, and chronic respiratory diseases. Why is that?
Well, you see, the healthcare in what has been known as developing countries has put most of its effort mainly on infective illnesses and infectious diseases, HIV being the commonest, and then the childhood infectious diseases, and so on and so forth.
Malaria as well.
Now, yes, malaria as well, polio, infective diseases. That is what the decision on how to stock the government drugs was based on, with emphasis on infective illnesses, because by a very large margin, that does contribute to a significant amount of morbidity and mortality. Though, as times are moving, the cardiovascular diseases are now coming up to actually contribute a significant chunk of morbidity and mortality. Therefore, the decision as to how to stock the MOH kitty of drugs is going to be shifting also because of this evolving situation as regards cardiovascular disease. But previously, it was rightfully organized that way because the bulk of our problems were infective illnesses.
So is there a shift right now that we can see information is giving us non-communicable diseases?
Not yet. Not yet.
Not yet?
Yes.
But what is the remedial measure that is coming? Not yet will not be a good answer enough,
A forum like this.
A forum like this,
will inform the public.
This is not just for Dr. Mutai, it's for all of you. Not yet. Why not yet?
Perhaps just to say, like she says correctly, if you are sitting in a position of power in the health sector, you have to set your priorities. And your priorities mean you have to look at what is prevailing and what you must deal with more often. And that affects the budgeting process significantly. So the reason why you're seeing what has been happening is because from the data available, it was more of communicable diseases. And now we're getting data that is saying that this is increasing. Unfortunately, NCDs, a lot of them are fairly expensive to treat, and they have fairly chronic issues. And so there's then a very big need that we must very clearly, deliberately look for a shift towards financing the care of these NCD and non-communicable diseases. And from where I sit, I look at the partnership between a body like NHIF and the government and the private sector. In fact, the future of healthcare financing, the private sector must be involved very bigly, so that this thing called PPP must come in. Because health is a big thing. Government will not be able to take care of everything else. And so we must involve a lot of other stakeholders to come in. And a good example has been set. If you look at, for example, the managed equipment service, he alluded to equipment being in most of the counties. It was a brilliant idea, so that you get people who have these things and you list them, they put them into the institutions, so you improve your diagnostic and your services. We need to tap into more private sector to be able to finance these things.
But has this also been a subject that you've broached maybe in your board meeting as well? You have Geoffrey here, and you, right? Now you should tell us if this has been a discussion that has been one of your agendas, family, in your program.
Yeah, definitely. Of course, keep discussing such. And of course, you can see the kind of steps that we are making. Like when we picked the cases that were there for cardiovascular, about 1,400 cases. And the key then was these people could not access services because they could not afford to cater for them. And we've seen the cost of initially from 2 million coming down all the way now to below 800,000 of taking care, depending whether it's open heart surgery or it is the closed process. So with more collaborations, with more focus on such, the country can move forward, and we should be able to say that we are able to manage our conditions and take care of our health needs in a wholesome manner.
Right. Let's hear from Dr. Makokha.
I'll say that the focus on this cardiovascular disease has, I'll say the journey is about 3 years. I think when the Kenya Cardiac Society pointed out clearly that, yes, we have a problem. And how they pointed out is because we had a lot of patients on the waiting list. And now various patients required interventions at the various levels. And the most challenging thing was accessibility, affordability, and availability. Those are the 3 main factors that were challenging the access to care for the patients with the cardiovascular disease in this country. NHIF came very handy to provide what is quite essential in the 3 pillars of taking care of a patient, which are, financing. Now, as soon as a patient is diagnosed and is eligible, the card is viable, is valid, then that patient qualifies to access care in whichever hospital that has that capacity. Now, what NHIF has done differently is they have given the cover private hospital and public hospitals. This has given an opportunity to the doctors in Kenya to reach out to these patients, screen down these patients, manage the patients, and give the way forward. That has created a positive impact in the care of cardiac diseases in the country. And that's the direction I think all other insurance companies should follow to support what NHIF is doing at the moment.
All right. All right. In a moment also we'll look at the prevalence of this particular cardiovascular diseases that we're talking about and the risk factors also involved. But we have a caller also hanging on the line. She's calling all the way from Nyeri, right? Ruiru, I'm being corrected there. We have Coletta hanging on the line. Good morning, Coletta.
Good morning.
Good morning, Coletta.
This is Nicoletta.
Yes, Nicoletta. Yeah, you have a question or a contribution for our panelists this morning?
Yes, I'm from Ruiru.
Yes.
First of all, I thank you so much for your talk this morning.
Yes, thank you.
And I say hi to Dr. Loice Mutai. Mwambie nimemsalimia sana.
Okay.
Okay, in the case of cardiovascular diseases,
yes,
I am a victim of a child.
okay. All right, the reception of that line is a bit spotty. I think we'll try and call back Nicoletta to reconnect it and get a clear line. Then we shall get a question or a contribution correctly. But let's talk about the prevalence. We'll get back to Nicoletta in a moment. And the risk factors involved. Hypertension has been, put up there as one of the risk factors that is, coupled with cardiovascular diseases. Why is that the case with the hypertension?
Well, hypertension is high blood pressure, higher than the accepted normal range for whatever age. And of course, you know, there will be different normal ranges for different age groups.
Yes.
Now, hypertension, especially as pertains to adults, the way it will contribute to heart disease is that in the heart there is a chamber called the left ventricle, which is the one which generates the pressure. If pressure is high, then that left ventricle is strained. And over time, the muscle of that left ventricle begins to thicken, and it begins to function abnormally. Its function begins to reduce. That is how it generates heart disease, because when this left ventricle is not working well, over time, the patient develops effort intolerance. They can begin to have swollen feet, breathlessness, and so on and so forth, basically from the strain that the high blood pressure puts on the left ventricle.
All right.
Therefore, one of the biggest issues about managing, especially adult heart problems, is to manage hypertension.
Yes, managing hypertension, but we want to see the causative factors for hypertension, given that now you've given us a clarity of what it is. But what are some of the causative factors that really contribute to hypertension? First of all, is it the lifestyle that now currently we have in this country? We have debates about GMOs as well, but I don't want to even broach that subject in itself, right?
Actually, majority of high blood pressure is what in the cardiovascular world is called essential hypertension. That means there is no clear cause.
There's no clear cause?
No. However, lifestyle does contribute to hypertension, amongst many other things, including diabetes and so on. Okay,
all right. Let's hear from Dr. Opot.
Well, like she says correctly, hypertension is quite a common public health problem, but like you said, majority are what we call essential. So that really, you can't point out and say this is what has caused it, but you'll find that diabetes, if you have blood sugar, it brings it in. Obesity, lack of exercise.
Lack of exercise?
Yes, consumption of excessive alcohol, sedentary lifestyle. So there are a lot of things in the lifestyle that can actually help you to control the blood pressure. Yes. But having said that, the problem with high blood pressure is that apart from heart disease, it also causes a lot of other damage. Because you see, the heart is like the central pump. If, for example, you look at Nairobi and look at the water supply, there's a place where it comes from. It has to have enough pressure to bring it to your house and all the other houses. So in this instance, if the pressure is too high, the people who suffer are the organs. So you'll find that the eyes will suffer, the kidneys will suffer, many other things will suffer. So it might be the beginning, but at the end of it all, it causes a lot of damage. And so those are the things that need to be controlled before you reach that level. Yes.
Right, I'm going to understand. We have Nicoletta back hanging on the line. Good morning, Nicoletta. I hope we can hear you clearly right now. Good morning.
Morning, how are you, Debarl?
All right, let's speak Patrick. Patrick, yes, good morning. How are you?
I'm okay, Debarl. How are you?
Very well, thank you. You have a question or a contribution from a panelist
yes,
this morning?
I've got a question.
Yes, please.
My question is going to the gentleman from NHIF. NHIF is very good and we are getting very good service, but it is very much limited because it only covers, like if you're not employed by the government, it only covers you for dialysis and the CT scan.
Yes.
Why would they not allow us to maybe top up this contribution from 500 so that we can get a better cover from NHIF? Because already what they're doing is good, but it's not enough.
It's not enough.
Especially for those people who are self-employed.
All right. Thank you.
Yes.
Thank you, Patrick. And Nicoletta, back. Yes. Good morning, Nicoletta.
To contribute on the factor of deceased children.
Yes, please.
Especially the treatment, it is very expensive. And so many children die waiting. So many children die waiting for the treatment in the queue.
Yes.
So we kindly ask the NHIF people to improve. We ask them to improve as the cooperators. Thank you so much for the talk.
Thank you, Nicoletta.
Thank you.
All right, let's just answer that particular question from Patrick. And I think this is falling right within the remit of NHIF.
Yeah.
You can clarify why could we up the ante, maybe raise it to, I don't know what amount will that be, and why have we settled on the 500? Is it because maybe it's, you know, at the center where the middle class and the lower rank also can afford it?
Yeah, those are some of the things we're grappling around with, and I know the civil servants have a very good cover because the employer has topped up and paid additional premiums for them. I know I've been receiving this question over and above. Why don't you open up and we do something?
Yes.
We are working on modalities to see how we can have an advanced cover. For the national scheme, for now, we have what we call super cover. And we've given what it covers about. And for the informal sector, the contributions are 500 shillings per month, 6,000 annually, covers for the whole family. You know where NHIF is coming from. And being a social health insurance, they are the metrics we use to lay out the premiums payable and to set out the benefits applicable on that front. But this is something which is coming up, and Kenyans are saying, indeed, we need to move further because health matters are really crucial, and they affect the whole family, they affect the whole nation, and we are working on something on that front. For us to improve, yes, that's why we came up with this program, cardiac program, because indeed we found there were kids who are suffering below 5 years of age, diagnosed with cardiac conditions, but they could not access the care they needed because of lack of funding. And this is the area we are saying now we are coming up and we are able to do cardiac. This program will move on because we have a surgical package. For specialized surgery, have 1 million shillings. So this is something we are saying now is sustainable. If you are diagnosed with such a condition, it is manageable. And so long as you are a member, we will fund your surgical cases. What we are looking at is to build local capacity. And that's what this program has done, to bring cardiologists together, to bring surgeons together, and see how do we bring in the costs of managing some of these conditions instead of shipping all of them to India, for example, or foreign countries.
Right. It is interesting also that you mentioned exercise. And what really boggles the mind is even some people who exercise a lot. We saw like yesterday with the Chelsea player, the former Chelsea player, former Ivorian Coast.
Former Newcastle.
Yes, yes, Newcastle. Yes. This is, we're talking about Tiote Chiek, who collapsed yesterday. We can have the pictures of him, and actually died. So when we talk about exercise and cardiovascular diseases, he was the former Chinese club player as well, and his agent confirmed that Tiote played for English club Newcastle United for 7 years before moving to China in February. And he was an African Nations Cup winner with Ivorians in 2015, although he missed the final through injury, and he played in 2010 and 2014 World Cups. You exercise a football player like that, you'll expect that, yes, maybe he's having a very good dietary regime, he's having a very good program where he exercises. But why do you collapse and die because of heart attack? This is what people grapple with. So I go to the gym because I want to burn my fat. You talk of obesity, but still, it will attack me. Daktari.
Well, exercise will actually help to control obesity. It will help, in effect, it will help to reduce the incidences of what we call coronary artery disease, where you form plaques clogging the small arteries, small vessels which deliver oxygenated blood.
Yes, but I want you to put into the aspect of Tiote right now. He's been exercising. We've outruled obesity.
Yes, just
lean muscle here. Lean.
Now, exercise will give you lean muscle, and will exercise together with healthy eating, where you are avoiding the polyunsaturated fats, you are avoiding many of these fast foods that are available all over and being eaten by young people.
Yes.
Those are the things which contribute to coronary artery disease, which gives you the kind of heart attack, which is the one which many people understand, okay? Related to healthy eating, related to exercise, related to lean body, and so on and so forth. However, there are other categories of heart problems which are totally not related to the body size. And that would contribute to the deaths of people who otherwise would look like they possibly cannot have coronary artery disease.
Yes.
For example, rhythm problems, the electrical activity of the heart. That's what makes the heart beat rhythmically in a certain way, a certain number of beats per minute. There's a system which controls how the heart beats.
Yes.
Now, if there's an issue with that, and sometimes you can't predict, you go and do a health check, and you look normal, everything is done, you look normal. However, those rhythm issues can come occasionally to some people, and when they come, sometimes there isn't time. It's not like you'll have it for a long time. Some people will have fast beating heart and you have time to go and get checked, and that issue can be addressed. Others, the thing can come very stormily and actually can take a life.
Right. But also I expect to hear maybe it could be that genetics also is a predisposing factor in this as well. That as much as I exercise, if it is coded in my genetics, it is bound to come through. Let's say from a doctor.
Actually, I know now that you've drifted over to football, and one of those passionate fans. You know, it's not only Czech Tote. I mean, there are many other players who've actually collapsed in the field.
Yes.
And one very prominent one called Kanunu Wanko. You know, in spite of passing through certain teams, when he was going to Italy, because they're very thorough, they actually discovered he had some heart condition that was going to endanger his life, and they sorted it out. So like she says, there are certain things that are not necessarily to do with the lifestyle or obesity or whatever, but they're actually happening in the heart, and they can strike at very short notice. Yes. And most of them are actually to do with the muscle. You know, the heart muscle is very specific. It has its own electrical rhythm. There's a place that has to produce the rhythm to make it to beat the way it's supposed to beat. And sometimes there are small issues with that rhythm, and that can make you die, even in very fit people. So yes, perhaps there might be an element of inheritance and genetics that causes that muscle to have that problem. But there are those things that are sometimes very difficult to diagnose.
It's very low.
Yes,
it's very low. It doesn't play an important part, except for people who develop thickness of the heart muscle. People who develop thickness of the heart muscle do have it in their families, but that is easy to pick. When these athletes go for medical checks, that is easy to pick, because when one does the study of the heart, a thing we call echocardiogram, that can be seen. So that will not hide.
Right. It's good also you've mentioned the echocardiograms, and we will discuss about this equipment also in the counties as well. But you being a pediatric cardiologist, and also the rising cases of young people, especially also children, having heart ailments, that you mentioned congenital factors as well. Could you kindly just give us also a scope of how prevalent it is in the country right now, and what are some, as I mentioned, of the causative factors as well?
Well, heart diseases in young children come in two categories. There are those which babies are born with, and there isn't much of an inheritance factor there. Occasionally, in very few incidences, actually less than 1%, there may be an element of inheritance. But the majority of the children who are born with heart problems do get their heart problems very sporadically. Okay. So they are born with these heart problems, and they grow with them. If they are not picked early and they are severe, then yes, they will cause a reduction in lifespan. Then there is this category of heart disease in children, which is acquired, rheumatic heart disease, which comes from a sore throat. Actually, by far, that forms the bulk of our heart problems in children. The congenital does contribute to about 3%.
And most people, they don't realize how very dangerous it is when a child says, "Mommy, I have a sore throat."
Yes, yes. Most children will have the sore throat. They may complain. Others actually will have milder forms of sore throat. It doesn't have to be very severe. Yes. The majority of the children who have rheumatic heart disease will have suffered very severe sore throats, which caused pus in the throat, pain, fever, and so on and so forth.
Thank you. Thank you. Because of time also, let me hear from Geoffrey, because we're talking about children here, and I don't know how, because we have insurance covers that gives you, your spouse, your family, your children. I don't know to the extent of NHIF where you've broadened this scope as well, when you're talking about children with cardiovascular diseases, heart ailment, and how far does your cover reach when we have a family?
Our cover is family-based.
It's family-based.
It covers children of 18 years and below. That is the spouse and children of 18 years and below. But if going to college of 24 years and below. So it's a complete cover, which is family-based cover. Yeah.
Okay, so and when it comes to maybe different categories, because I can see where we have this particular NHIF benefit structure of 2017, maybe I can also show it to the viewers where it's well laid out for you. I'm doing a poor job. I should have actually made graphics of this. But there you have it. You have the outpatient cover. You have being one there, and also chronic illness, and diabetes.
Yes.
Also, there is a surgical package. This is where now we're talking about now heart ailment as well. I'm just going randomly. And we have also radiology, MRI, CT scan as well. Here also is where the bulk of Kenyans benefit from, the oncology and chemotherapy and radiotherapy as well.
Yes.
We have the overseas treatment. This is now when we're talking about medical tourism, right? And I know we've been working in concert with a country like India, but you can tell us also where you can go as well.
For cases that purely we can't manage locally, and this is what we are trying to do. Like some of these cardiac cases used to be taken out of the country, but now we have managed to work with our local surgeons, with our local cardiologists, and we can manage them here. Because what we lacked is the proper management and how the proper logistics, basically. Let me say, talk about logistics, to know which facility can be able to do what combinations do we have. And we've managed to do that. Delivered 238 cases now done locally. So our expertise in here is there. Save for where we would lack the type of equipments, like in the PET scan and all this, which we should be focusing in the future. There's another key area, which is the kidney transplant. And part of those have been done abroad, and we are saying we are looking to have a program whereby we can also do the logistics and have our local expertise.
And which is very cheaper, even doing it here in the country. People, they've not really realized the benefit of actually doing the kidney transplant here in the country. Is it because of a sensitization that is not enough, and the public is not really aware that you don't really have to travel to India, which is far much expensive? We have expertise here in the country who can actually treat this, and NHIF also is really coming in handy on how also they can go forward and try to make sure that waiver some of the medical expenses that come with it as well. So this is the kidney transplant. You can do it actually in the country right here in the country. Also renal and dialysis. This is the biggest as well when it comes to the kidney failure.
Yeah, it's very expensive, and you don't get dialysis, you die. So it's very expensive, and this is where we brought in the kidney transplant, because dialyzing is not curing you; it's just offering a remedial course. But the real thing is, we get a kidney transplant, then you are able to get back to your normal life after some time.
All right. Yeah. Also, Kenyans, I think, also they'll be happy with the maternity package as well. There is also the bill, the mother's bill, which is, I think, I don't know if it's gone on the first
reading in the House. We have a very elaborate maternity package. The only thing we are saying now, we are seeing CS cases, that is cesarean cases, rising up. And they should only be of emergency in nature. But that is, I think, is a world over problem. It's not a Kenyan issue. I think
maybe also the aesthetic purposes of women who don't want to go through the normal delivery, because they want to.
The distinction really to know it was emergency in nature. It's a very slim line. Very slim line.
Collusion with doctors.
Exactly. They're here. I didn't want to mention that.
Yes, let's hear from Makokha.
That explains why ANK Global Health partnered with NHIF and to provide an expertise in management of like cardiac conditions that we are talking about now. And this is a very noble program that is running at the moment. And we brought in the aspect of measurement, that is looking at the clinical outcome and holistic, the whole process of management of the patient, from the diagnostic treatment, then follow-up of the patient post-operatively, and then also from there, the aspect of screening and prevention and health education of the community. So all that expertise we have actually provided to NHIF, and this has really given a lot of positive outcomes to this particular program. As he has rightly mentioned, a lot of cases have now been supported in this program, and we look forward to support more.
All right. Yes.
Actually, just to add on that, the ultimate aim of the healthcare financing that NHIF is pushing, and the reason why we work with bodies like AK Global Health, is that ultimately is to build capacity in this country and enable the people who are here to do what they should be able to do. Because previously, a lot of people think that Kenya has no expertise to do these things and all that. It's an issue of information passing there and providing the logistics, particularly the financing, to enable things to be done locally. And so for me, it's a very exciting frontier. And perhaps we should go ahead and explore a lot of other areas of collaboration.
All right.
Yes.
Okay. As we also are planning to wind the conversation, the issue of equipment, because you raised this and you talked of echocardiography,
yes.
And all devices that also will be deemed routine diagnostic in the West. We don't have them in the counties, right? And looking at the headlines, because I'll be remiss also if you don't really talk about what is on the front page of a Daily Nation, if you may just pick up that, so that, the nurses are dancing in the streets as patients die. And maybe one of the reasons it could be because they're actually, aside from their collective bargaining agreement, poor facilities in the counties as well. We talk of echocardiograms and other devices as well. Could you just comment on this very briefly?
Well, like I said...
let's hear from Dr. Mutai,
yes,
and then we'll come to you.
Okay.
Very briefly, madam.
Yes. I just want to correct you a little bit, to say that echocardiography machines, the echo machine, is actually available at the counties.
It's available?
Yes, it was provided some years back. About 61 units were purchased and distributed to various level 4 and level 5 hospitals.
All right, but I don't know how recent was this, but this is what I did my research. It says that an inquiry amongst health workers on availability of basic diagnostic cardiology equipment in counties hospitals, it was apparent that county health departments have not prioritized such equipment. Indeed, less than 10% of accident and emergency or casualty hospitals departments have ECG and echo diagrams devices.
What is not there is ECG, but the echo machines are there. However,
but ECG is very key.
There's a little catch. There's a little catch about the echo, in that this equipment were bought and distributed all right, but the utility has not been that great, because at that time there weren't trained personnel who could use the equipment, but the equipment is there.
Thank you.
What is not there is the ECG, which, as you say, yes, it's critical. It ought to be there.
All right. And I think NHIF, you've come to the show and say that MRI and also the CT scan reimbursement plan and the dialogue, a good patient-centric business model can be reached, right? Is that true with the equipment? Are you frustrated?
Well, you see, for us, we do what we call strategic health purchasing.
Yes.
And our members do not rely on the public health facilities.
Yes.
But we are saying, indeed, that could come in handy if these equipments are readily available to avoid or to create quick access to health services.
Thank you.
But then adding to that, the fact that you have invested in this equipment and you're sure that your costs will be paid when somebody comes, that already makes you very comfortable. It means you can maintain the machines and the service can continue. And so NHIF comes in very handy, because you've got this package. If you come in and have a CT scan machine and I do the service, previously it was unpredictable whether I'll be paid or not. So a lot of times you were not even able to maintain your machines. So that sustainable financing that allows the machines to be maintained and for the services to continue being delivered. Yes.
Lastly, also, I think on Monday we had the Business Daily raising this particular alarming story about medicines as well. I just want to show you what it entails there at the bottom, that fake Chinese India drugs put Kenya at risk. And this is a study by the UN, which has ranked Mombasa as a major hub for trafficking of fake pharmaceutical and veterinary drugs, putting millions of lives in danger. The study by the World Customs Organization and the International Institute for Research Against Counterfeit Medicine cites the Kenya Port City as being among the biggest. So we have influx of fake drugs in the market right now. How do we tell which is good and which is dangerous?
I think Dr. Masinde here has a bit of insight in that field. He can...
Dr. Masinde, just clarify very briefly on this.
I will say that I may not be the right person to comment on this, because we have got a legal body, which is Kenya Pharmacy and Poison Board, that's supposed to regularize and ensure that all the drugs that are coming to this country are of efficacy and they meet the minimum threshold. Of course, we are all talking about clinical outcome. for us to attain that, we have to ensure that the type of drugs that we are using are drugs that meet the international standards. So it's up to this regulatory body to ensure that these fake counterfeit drugs do not find their way into this country. I know it's quite challenging to really put everybody on the spot, but I think they're doing their best, and I'm sure they're going to take action on that.
Right. Dr. Mutai, very briefly.
Ideally, all drugs which are being availed to the members of the public, the Kenyans here, ought to have gone through the Pharmacy and Poisons Board for check, for standardization, acceptance or rejection of the same. However, much as quite a number of drugs will come through the Pharmacy and Poisons Board, there are other channels which bring in nearly what one would almost call illicit drugs, drugs which have not been subject to those tests. Those who go through the Pharmacy and Poisons Board are reliable drugs. They are found in pharmacies all over. The ones which sneak in are also bought, especially by pharmacies in places where even when the Pharmacy and Medical Board, even when the Medical Board goes to do checks, because periodically the Medical Board, together with the pharmacy industry, actually goes to do checks, to go and look at the drugs which are being sold. But most of the time, those drugs, you may find them, you may not find them. Majority of the times, you don't find them because the people who sell them know that they are not good drugs and they are not necessarily exposed. You come, if you cannot afford this drug, they tell you there's another one on this side. So what we could say here is that the government needs to tighten the entry points so that these drugs which are not standardized do not reach our market.
Thank you. And I'll be remiss if we don't talk about the biggest, just briefly as we're winding up, this is your final say as well, the cardio conference which is happening tomorrow at Pan-Afric. And of course, you've invited different stakeholders. We had cardiologists, pediatric cardiologists, intervention cardiologists. I think also the society, the Kenya Cardiologists Society as well. Just give us a brief of this. What will be happening tomorrow? Either Dr. Mutai, any one of you, or also Mr. Mwangi, to tell us why this conference, why tomorrow, who are the stakeholders, the public and the private, who is invited?
Maybe I can talk a bit about that. What exactly we are doing is to bring the various surgeons, cardiologists who've been involved in this program. And part of capacity building is to bring these people in one round table. They share their experiences. Yes. They talk about it, they share their experiences. Where are the challenges? Where do we have the gaps? What can we do to improve? That can only happen if Dr. Mutai here and the colleagues come together. Otherwise, in their own clinics, they will never get to talk about. They are very busy people. So we are trying to organize and mobilize, bring them together. Then from there, we can have meeting challenges. We can have capacity issues where we like. We can have issues to do with what else do we need to do to have such programs up and running.
All right. Thank you very much.
Actually, just to add to that, probably you're aware that NHIF is 50 years since it was established.
Yeah, we celebrated that, commemorated that.
So actually this program of doing cardiac interventions for people with cardiac diseases, it's one of those things that we put in as part of the 50-year celebration. But it will still continue, like you said.
Thank you.
And so deliberately, as part of the packages, we put, because it's a big impact kind of move, and it really works well with the Golden Jubilee. And so part of the meeting tomorrow is to come and review this thing has gone on for this period of time. Yeah. What are the results? How many cases have we done? And how do we go forward?
To be very clear, the Golden Jubilee, which is 50 years. Yes, not the Jubilee, the party.
Yes.
No. All right.
No. Thank you.
And as the doctor has just mentioned, tomorrow will be NK and the rest of the participants will be presenting the data of the progress we've made in this particular program since we began. We'll be giving them measurable indicators towards this program. And as he said, it's a transformational thing, especially providing life to somebody who otherwise could have died.
Thank you.
We've reached to about 259 patients, and many others are now being managed in the program. So tomorrow is a workshop that we're bringing people together. All right. Show them what we've done. And then from there, we map the way forward. What can we do differently to even reach out to bigger numbers?
Thank you very much. Dr. Mutai, also very briefly, your closing comments.
Well, we are excited in the cardiovascular world that NHIF did come on board to help our patients. We have a huge patient load both children and adults who have issues which require either medical treatment, intervention treatment, or actually open heart surgery. Since NHIF came on board, we have actually done so many cases in such a short while. Previously, we would be doing something in the region of 200 the whole country, or the hospitals which do heart surgeries together, something in the region of about 200 cases a year. Right now, we are only half a year, and we are nearly 300 cases. And I'm sure by the end of the year, we might be talking about 700-800 cases.
Thank you.
So that is great for our patients.
Thank you.